We five of us on the stage and five of us in the audience side. Yeah, and we appreciate the previous speakers who are waiting to listen to us. Thank you. And 4 audiovisual people are there, so it is very nice. We thought we can have a roundtable discussion, but luckily there are some people in there. Anyway, kudos to this organizing committee, Dr. Manoj, Purvi, Bansi and the entire team for this wonderful conference. Welcome to our panel discussion on in-hospital diabetes management. So we have an esteemed panel of experts with us, Dr. Vinod, Dr. Seema, Dr. Sonali, Dr. Reshma and Nadia. Welcome to our panel discussion. And the audience expect your expert insights and experiences on managing the diabetes in the in-hospital setting. So all of us will agree that diabetes is a common comorbidity among the hospitalized patients. It affects around 40% of the inpatients. So in-hospital diabetes management is crucial to prevent adverse outcomes such as hypoglycemia and hyperglycemia and an increased length of stay. But diabetes management in the hospital setting can be challenging due to factors like variable oral intake, medication changes, and stress-induced hyperglycemia. Yes, ADA says there are concerns in managing the hyperglycemia in the hospital setting. That is, in the hospital, both hyperglycemia and hypoglycemia, they are associated with the adverse outcomes, including death. On admission, if the blood sugar is more than 200 milligram percentage, there is a higher risk of complications and death, even in the non-ICU setting. And diabetes and the complications. Diabetic patients are associated with the complications, most of them. These complications, severity increase the hospitalization and increase the treatment cost. So, critically ill patients, they are associated with higher rate of mortality. So, there is a twofold. The severity of the blood glucose increases, there is a higher risk of mortality, twofold, threefold, and fourfold. Yes, hyperglycemia is very common in the critically ill patients, and glycemic targets, many guidelines they are accepted. Fasting and the pre-meal less than 140 milligram percentage, random blood sugar less than 180. So what is the mantra when you want to treat a patient, inpatient, with the diabetes management? One mantra is either no hypoglycemia or minimal hypoglycemia. So we need to choose the therapy, choose the insulin, probably modern insulin, analog insulins, to minimize the risk of hypoglycemia, because even a single episode of hypoglycemia associated with lot of cardiovascular outcomes, adverse outcomes, and there is a risk of mortality within the 1 year of the discharge, and also the risk of hypoglycemia, one episode of hypoglycemia increases the hospital stay and everything. So let us move on to there are a lot of questions in the inpatient management, diabetes management. Actually, this topic will need minimum of 1.5 to 2 hours. We are concise to 30 minutes. So let us take up some 10 questions, important challenges. Each one of the expert, they will take up 2 questions. At the end of the all 10 questions, if there are any question, we can take up. To Dr. Seema, yes, all the patients on admission, we used to do a random blood sugar. This is a quite common thing. Do you want to stick on to only random blood sugar, or you want to add HbA1c on admission?
Yeah, this is a very practical question. It's a very practical question that whether we should do HbA1c on admission. So HbA1c testing is recommended by many of the organizations like ADA, Endocrine Society, EASD, although it is not compulsory. So I will divide my question as whom should we do and why should we do. So HbA1c should be done to all patients who are diabetic and who have not done blood sugar in last 3 months. Second category of the patient would be those who shows more than 140 blood sugar on admission.
Yeah.
And third category, those patients who have comorbidity or risk factors like metabolic syndrome, obesity, and who come with the acute illness. So in all those patients, we must do HbA1c. Now, why should we do? Number one is all diabetic patient. It will show that whether your diabetes was under control or not. So and secondly, whether patient has developed high blood sugar now in the hospital or whether patient was having prior to that. So it will differentiate between a diagnosed diabetic patient and a stress hyperglycemia. Secondly, this will also tell you, the HbA1c will tell you in a diabetic patient that patient's blood sugar was under control or not. If it remains high, that means it was very high, uncontrolled, and patient will intensify. We have to intensify the treatment.
Yeah.
And it will also decide the line of treatment. That patient may need, treatment or OHAs or insulin for a longer time to get the better outcome.
Exactly. Well explained. One more thing, undiagnosed diabetes also, because many of our patients, they don't do any test at all. They may be a diabetic, undiagnosed. On admission, when you do it, we can detect the undiagnosed people also.
Yeah, so basically, if we check the sugar, it is high, but HbA1c is normal.
Yeah.
So that will tell you it is a stress hyperglycemia.
Exactly.
So if the HbA1c is high and sugars are also high, that will tell you the chronic glycemic status of the patient. That patient is a diabetic and it was not under control.
Absolutely, ma'am. Absolutely. Yes, we are talking about blood sugar and we are talking about HbA1c. Now the latest metric is CGM. Yes, all of us agree that CGM is very, very useful in the outpatient setup and well documented. What about the role of CGM in the inpatient management? Dr. Nadia.
Thank you, sir. Thank you for your question. So I think in today's world, CGM, continuous glucose monitoring, is very important, especially in our hospitalized patients. It can be different for the ICU and for the wards. So let's start with the wards. So firstly, we know we have real-time and intermittent CGMs. So with the real-time, we can see it every 1 to 5 minutes. With the intermittent, we can see it up to like 15 minutes. We can have a sugar chart. So it saves our patients first with multiple pricks. Like if our patient comes in with real high sugars, we have to put them on an insulin pump. We have to monitor them at least 2 hourly. So that is one thing. Second thing, it saves our staff from the stress of continuously monitoring. So that's easier for them. Most of our patients are not very well eaters. They go on liquid diet, they go on parenteral nutrition. So a CGM is going to help us monitor. It's going to show us it's going to alert us when there is a hypoglycemic event. It shows us the trends, whether the next glucose is going to trend higher or lower. So there are multiple benefits. But yes, at the same time, when there are critically ill patients in the ICU, it can have a lag of up to 15 minutes since it's the interstitial fluid. So in such cases, when we have our patients in sepsis and shock, we avoid using that, and that time we prefer using the capillary blood.
Yeah, you are absolutely right, ma'am. For the outpatient setup, it is well established. It is documented according to all the guidelines. But no guidelines support the use of CGMs in the acute illness, ICU patients and surgical patients. So, future it may come. As on date, that is use of the CGMS for the acute patients is not advisable, but you can use for the stable patient who are eating regularly in the non-ICU setup, whereas it does not replace point of care glucometers. With the CGMS, now and then we can cross-check with the glucometers.
Absolutely.
To Dr. Vinod, yeah, now it is era of using the GLP-1 receptor agonist, and nowadays we are using the tirzepatide as well as semaglutide, everything. This type of patient, when you come to your nursing home and you get admitted for acute illness, how will you manage? How will you, what is your approach?
I think this is quite relevant. I mean, with more usage of GLP-1 and GIP, which we are now, everybody is going to face this kind of patients more in the future. So for patients who are on GLP or GIP, the dual agonist, I mean, they basically needs individualized approach. The first important thing would be assessing the patient to know for what reason the patient has been admitted for. Is it an acute medical problem? Is it an acute surgical problem which the patient has been admitted for? If it is a surgical problem, is the patient going to undergo any surgery in near future? For them, I mean, a patient who is planned for surgery, for them, you will need to stop the GLP-1 because we know that it affects the GI motility, so it can cause post anesthesia, it can cause aspiration, all those problems. Second thing would be the medical condition. For what medical reason? Is it a cardiac reason, a renal reason, a GI reason for what the patient has been admitted? Then knowing the patient's status, is he stable, hemodynamically stable, is he eating and drinking well, is he having nausea, vomiting, all those things needs to be considered. So if the patient is in ICU, so most of these patients are quite, they're not stable, and for them, most of them I would say we would need to stop the GLP-1 analog. Then any patients with the GI problem who has got nausea, vomiting, again on those kind of people also we cannot continue with the GLP-1 agonist and all those things. Only patients who are stable, who are eating and drinking well, who do not have any GI problem, for them we can continue. But again, it has to be with strict monitoring, so that we have to see that he is tolerating, he doesn't have any acute nausea, vomiting because of the therapy and all those things, frequent monitoring, all those things. And in patients whom we stop GLP-1, then we have to be concerned about the sugars going up, and then we'll have to readjust whatever the insulin or medicines what he's taking.
Yeah, you have beautifully covered all the points. Wonderful, because it is a year of higher use of GLP-1 RAs. So we have to educate the primary care physicians. To Dr. Reshma, yeah, we are talking about the hypoglycemia. Hypoglycemia is a common issue with the insulin, everything. And so we need to prevent it, we need to manage it. How you are going to educate your patient and staff nurses, and how you are going to prevent and manage?
Yeah, so hyperglycemia has many adverse outcomes, increases the hospital stay, increases the mortality, so also hypoglycemia. So we really need to identify it and prevent it. In fact, you showed a very interesting slide, sir. One episode of hypoglycemia is going to increase the mortality to the tune of 64% and overall mortality in future to a great extent. So it's really imperative on our part, as well as the way we educate our RMOs, nursing staff, and the patient attendant also. So primarily we need to identify what are the causes of hypoglycemia. And I think iatrogenic hypoglycemia is an important cause for inpatient hypoglycemia, since the patient is generally on insulin. And there are other causes, like it could be patient factors, severely ill patient, or a patient with multi-organ failure, or a patient with renal or hepatic disorders for that matter. We all know that they are prone to more hypoglycemia. Overzealous treatment with insulin. We have this binding on us, in hospital setup to give a good glycemic control to the patient. So that also causes overzealous treatment, which can lead to increased propensity for hypoglycemias.
Or it has adverse outcomes. It can lead to cardiac arrhythmias and seizures and brain damage and increase all-cause mortality for that matter. So how you're going to prevent the hypoglycemia? And another thing is chronic diabetic patients may also have hypoglycemia unawareness, because of which the symptoms could be masked and the patient can fall a prey to an episode of severe hypoglycemia. So I think good monitoring strategies, instruction to the staff basically to monitor the pre-meal glucose levels and only then to give the shot of insulin is very imperative. I suppose the patient's attendance needs to be educated thoroughly, and of course CGM should come in handy, especially in a non-critical care setup to prevent episodes of hypoglycemia. In fact, what I found was when we are giving the basal bolus regimen, the addition of basal insulin, for that matter glargine, can also lead to episodes of hypoglycemia, which I have seen practically. So we need to taper and titrate the doses of the shock-acting insulin in a proper way, to manage hypos.
Exactly. So we need to educate our staff nurses. That is very, very important. And documentation is very, very important. Sometimes double the dose, that happens, so many things. The analog insulins like Tresiba, everything, double dosing doesn't make much impact. Whereas with Detimer and Glargine, everything, double dosing causes a risk of hypoglycemia. So we have to educate our patients about the signs and symptoms of hypoglycemia, and our staff members, they should be well versed in managing, identifying and managing the hypoglycemia. Wonderful, ma'am. Dr. Sonali. So, inpatient management, there are a lot of regimens. Some of the patients, most of the patients in India, they are very fond of premixed insulins. One talk was there with the premixed insulin. Most of the doctors, they prefer premixed insulin both in the outpatient and the inpatient setup, and they land up in a lot of hypoglycemia. What is a regimen you prefer and what type of patients?
So this is a very important question, and we all should, really address it well, because we heard from her that it is hypoglycemia which is so important. So hyperglycemia in inpatient patients is so common, and most of the time insulin is the preferred choice. Now how you are giving insulin makes a very important decision, because usually, as Sir said, that it is the mixed start which has been continued, and that gives a lot of problems. Many international and national bodies have given us the guideline as to use the basal bolus regimen, and now a new concept and a new terminology in this term is basal bolus correction regimen.
Exactly.
Because the correction is something which is very important for the IPD patients, because of the stress hypoglycemia, because of the acute illness which the patient has, also the hepatic renal involvements which can occur. So it is basal bolus with correctional dose. That is something which is very, very important.
Yeah, wonderful. Sometimes when the patient is on enteral feeding, continuous enteral feeding, for those patients we can go for only long-acting basal insulins. Sometimes the intermittent feeding, we need to go for basal bolus. So depending upon the situation, depending upon the patient needs, you are absolutely right. We can decide whether basal only or basal bolus with the correctional. Thank you, ma'am. Dr. Sima, yes, the role of the OHAs and the insulin, many of the patients on steroids, corticosteroids, they develop hyperglycemia. We are in the outpatient, we are using for a mild hyperglycemia with the steroids, we use glycoside, etc. For the inpatients, when they develop steroid-induced hyperglycemia, will you prefer OHA or OHA plus basal bolus? What is your opinion, ma'am?
So, steroid-induced hyperglycemia is very commonly seen in hospitalized patients, especially with the glucocorticoids like prednisolone, dexamethasone, and methylprednisolone. So we have to make sure that the blood sugars are maintained between 140 to 180 milligram. There is no hypoglycemia. And then we have to plan the strategy if the blood sugar remains high. Now we have to decide whether the patient to be prescribed oral hypoglycemic agents or insulin. So in the hospital setting, generally oral hypoglycemic agents are not preferred. The reason being that they have delayed onset of action. In the hospital setting, we need to control sugar fast. So it is unpredictable with the OHAs. Also, some patient, we don't know the intake of patient, whether patient will eat or not. So depending upon that, if we give oral or hypoglycemic agent, patient may go into hypoglycemia. Also, certain drugs, we have to be careful when choosing the oral hypoglycemic agent. Something like metformin, we generally don't give in hospital setting if the patient has underlying renal or hepatic impairment. Secondly, with SGLT2 inhibitors, patient can have dehydration or ketosis or genital urinary infection. Sulfonylurea, of course, can cause hypoglycemia, especially when we know that the patient's oral intake is not there. So these three drugs are generally not preferred. Maybe DPP-4 inhibitors can be given in those patients where blood sugars are mild and patient's stay is short in the hospital. So DPP-4 inhibitors are still preferred. Now coming to the insulin part, it is the most preferred therapy for steroid-induced hyperglycemia. And again, it will depend on the type of steroid and the time of steroid. Now suppose if the patient is on shorter acting insulin, steroid, like prednisolone, which if we give in the morning time can cause, its peak action in 4 to 6 hours. So generally we give in such patient the NPH insulin, so that both the action of steroid
Matches.
and NPH matches and we can, have a good glucose control.
Yeah.
But if the patient is on longer acting insulin like pentyl prednisolone, then in such patients generally basal insulin is preferred, and to cover the prandial glycemia we add bolus insulin. So generally basal bolus therapy is preferred in steroid induced hyperglycemia.
Yeah, well explained, ma'am. Some of the stable patients, clinical condition is very good. Eating is good. Then for those patients, you can go for once daily prednisolone 5 milligram. For those patients, we can very well use glycoside 40 milligram. That matches pharmacokinetic effects. As you rightly pointed out, for other patients, patient is not taking food properly or high hyperglycemia, all those things, then it is ideal to go for the basal and bolus insulin. Recently, there is one study from the European Institute of that is Internal Medicine. They have shown that patients are taking steroid-induced hyperglycemia, poor glycemic control with basal bolus insulin. For those patients, instead of increasing the dose of the basal bolus, they can go for this NPH insulin.
That is the third insulin which is
that insulin. This is a recent report. But whatever may be, whether we are using basal bolus and adding the NPH over and above, we need to have go for a regular monitoring. That is very important. Thank you, ma'am. Yeah, Dr. Nadia. Patient with heart failure and hyperglycemia, inpatient setting. Outpatient setting, you used to give SGLT, DAPA or EMPA for the cardiovascular benefits and the prevention of the that is heart failure, hospitalization, everything. The same patient, acute heart failure, when it admitted with hyperglycemia, what is your takeaway? Whether you will continue the DAPA or EMPA or initiate or withhold? What is your opinion?
So, thank you, sir. So, like we know, SGLT2 is one of the pillars that we use for heart failure, one of the drugs. And simultaneously, the action is because we know at the SGLT2 site in the proximal tubule, it's going to push out the glucose to the urine, right? So there is a lot of diuresis. So that's going to reduce the preload on the heart. Similarly, it's going to help reduce the blood pressure. So it is a very good drug when we have our patients with hyperglycemia, even with heart failure. Hypoglycemia is going to even reduce the fasting, post lunch, and even in insulin resistant patients. So yes, I do see it as a good drug in our patients with heart failure and hyperglycemia.
Yes, ma'am, you are absolutely right. But only one thing I would like to add on it. In patients, acute heart failure,
Left ventricular
acute illness,
we avoid.
yeah, we have
Left
to avoid
ventricular we avoid.
because there is a high risk of diabetic ketoacidosis,
Yes.
all those things.
Yes.
So outpatient setup, okay. Inpatient, we have to monitor. Once acute crisis is over, the patient becomes stable, then we can initiate the
Yes.
DAPA or EMPA at the time of discharge for the long-term benefits.
Yes.
Thank you,
Acute
ma'am.
heart failure avoid. Yes.
Yeah. Dr. Vinod, stress hyperglycemia, and what is it? How will you define? How will you manage?
So basically, stress hyperglycemia is a transient increase in the blood sugars, which is seen in patients who are admitted for any acute medical condition. It can be medical condition, trauma, infection, MI, anything. And this can happen in even patients who are not known to have diabetes before. So this is actually stress hyperglycemia. It's mainly driven by the counter-regulatory hormone, the stress hormones, what we call as the catecholamines, the glucagon, cortisol, all those things. They drive the sugars to go up. And why it's important is it's because we know that any hospitalized patients, if the sugars are not within set parameters, the mortality goes up, hospital stay goes up, and therefore this needs to be diagnosed. And the way you can diagnose is basically by blood sugar, and second, as we have had a discussion before, checking the HbA1c. So HbA1c can help us to know whether this is a chronic hyperglycemia or it's just a recent surge which we have. So even with stress hyperglycemia, the targets which is defined how to manage, I mean, when we are managing the patients, the target is similar to what we have in patients with diabetes. So you have to keep the blood sugars between 140, 180. That would be quite ideal, with avoiding hyper as well as hypo. And then mostly these patients would need insulin because the sugars are usually very high. If it is not that high, if the patient is stable, we can try with OADs. But most of them we need insulin. And finally, our last point is that the reassessing these patients after at the time of discharge is also important, because in many cases the sugars may come back to normal after the acute this thing has gone. So reassessing them and then giving them treatment as per the blood sugars prior to discharge, and then calling up them for follow-up, that I would say would also be quite needed for the patient.
Yeah, well covered. The carry-home message is, on admission, doing the HbA1c is very important to differentiate between this and that. Dr. Reshma, in most of the nursing homes, even today, in our part of the country, they use sliding scale insulin regimens, and many patients, they land in hypoglycemia, lot of risk, everything. So we need to educate. What is your opinion between the sliding scale insulin and basal bolus insulin regimen?
Well, sliding scale technique, I think it's akin to a Hindi movie scene where the police come after everything is over.
Exactly.
Yeah. So once the damage is done, there's hardly any point in, intervention. So it's like a retrospective.
Reactive.
It's retrospective, but we need to be proactive and prospectively prevent hyperglycemia for that matter. It is obsolete. No guidelines recommend it. But unfortunately, in most of the, even international hospitals, all over the world, I mean, sliding scale technique is still used by the residents, by the physicians, by the consultants. It's like a knee-jerk reaction कि sugar बढ़ गया तो ठोको insulin, literally, sir. मतलब 20 units, 25 units, 30 units, and then the patient lands into hypo. So there is always a fluctuation between hypos and hypers. There is never a smooth control. Most of the studies show that it is ineffective. So it is obsolete. It needs to be abandoned. Basal bolus technique or the regimen is any day implemented. But most of the residents or the staff, I feel, is for the fear of hypoglycemia that they are implementing this technique. In a person with no prior history of diabetes or stress hyperglycemia for that matter, where we are not sure about the insulin requirement, I think a low dose bolus regimen should be started, and it should be titrated likewise, and so that even hypo and hyper can be prevented in a more efficient way.
Yeah.
That's what I feel.
Yeah. ಈಗ quoted a cinema movie also. Very nice of it. It is actually for many of the staff members, nursing staff, this sliding scale is easy for them. That is the only advantage. Otherwise, it is not physiological. And also it is a reactive one. Our basal bolus is a proactive one. We have to prevent the hypoglycemia. So we have to educate our staff members. And Dr. Sonali, I think it is a final one. So adjusting the insulin doses based on the blood glucose fluctuation during the inpatient setup, and how do we ensure medication safety and prevent the mistakes in the insulin injections during the hospital setup?
So this is also a very important question, and to answer to the first one is we have to keep on monitoring the sugars. Fortunately, we have CGMs at hand, and it avoids the multiple pricks, and we can even the CGMs can give us the trends of the sugar. So that is something which is very, very important. And if CGM is not really, we can say, affordable, then we can go for multiple pricks, and usually it is the pre-meals that has to be monitored so that we can time our insulin accordingly. To prevent the medication related, I guess it's a insulin medication related mistakes, we have lot of things to do in the hospital setup, right from choosing and doing the mistakes in picking up the insulin, Sometimes it is the short acting which is picked up against the long acting. Secondly, the syringe, if it is used, probably that is something which is very, very important factor, because most of the time it is seen that the nurses gives insulin from the cartridges with the 40 unit syringe.
Yeah.
That gives havocs, and it is never understood by the nursing staff, how much ever we explain them. So that is also very important. So right from picking. So secondly, there has to be a strict protocol. The instructions has to be very clear. Even while writing the insulin number, we have to be very, very careful, because many times it is the units has been written. So it is like 4 units, and then the nurse give the 40 units.
Exactly.
So likewise also mistakes happen. And I think most of the mistakes happen with insulin dosages, the timings. Most of the time the patients are not in place. They go for x-rays and MRIs and whatever investigations. So that time also there is some confusion as to whether to give or not. So I think giving the right protocol, and secondly, most important is giving the right instructions. Writing on the paper is something which is very, very important to avoid all those confusions.
Yeah, wonderful. Mostly nowadays, previously in India only U40 vials are available. Recently we have U40 as well as U100. So matching U40 vial plus U100 syringe. Many of the friends in the abroad, when they come out, they bring some U100 syringes. Patient will be using the U40 vials. That is a mismatching is a problem. And selection of the site rotation, needle multiple use, so many things are there. Some of our patients during the inpatient setup, outpatient, they give the injection through the clothing, all those things. So a lot of things are happening. So we have to sit with the patient, educate our staff nurses and tell everything. Then only we can overcome all these issues. Thank you.
I think, sir, for preventing any kind of medication error, it is important that we follow the 5 R's of giving a medication. That is the right patient, right medication, right dose, right route. I think if this is implemented properly, most of the errors can really be prevented.
Exactly. When the doctor, he is willing to spend some 10 minutes with the patient, it is more than enough. And our staff nurses should be very, very sincere to the patient, then it is okay. Thank you all the expert panelists for the wonderful deliberation. Thanks a lot.
Thank you to the audience too.